I want to introduce our next guest speaker, Dr. Teresa Petrella. Most of you will either be aware of her either as your own excellent physician or by reputation alone. I've worked and had the pleasure of working with Teresa now for quite a number of years, and you know, we couldn't be more privileged in this province to have somebody of this caliber treating us as patients and with such a caring and compassionate demeanor. As you know, she's a medical oncologist here, associate professor at University of Toronto. She joined the staff here in 2002 and became the head of the Melanoma Disease Site Group and the Melanoma Site Group here. She also chairs the Provincial Guidelines Melanoma Disease Site Program in Evidence-Based Care. So she helps set the guidelines for treatment in the province, along with many other very talented physicians. She's currently the chair of the National Cancer Institute of Canada Melanoma Clinical Trials Group, as well as the Canadian Melanoma Task Force. Her research interests are in melanoma and breast cancer, and she's currently the principal investigator for several multi-center trials investigating novel therapies in melanoma. Teresa, welcome.
Thank you very much. And every time I hear that being read out, like my whole life flashes before me. I still find it hard to believe that it's been 15 years since I started working here, and time just goes by really, really fast. But again, I also want to thank the patients who were here, part of the panel. It was very brave and excellent of you to share your stories and tell us what your journey has been like. And I learned what the doorknob syndrome is, so now I know what that is. Because I hadn't heard that before. So with that, I'm going to talk to you about immunotherapy and some of the other melanoma treatments that some of the people have mentioned already. As we mentioned, there has been a lot of changes over the last several years and a lot of new treatments, and we'll talk about some of those. So I'll just give you a little bit of introduction about melanoma. We'll talk about what adjuvant treatment is and what's out there in the horizon in the future. What are clinical trials, and go through some of that information, and then as well as talk about what some of the new developments are and what some of the side effects are for these new treatments that we have and things to watch out for. So in terms of melanoma, it's not the most common skin cancer. The most common skin cancer out there is basal cell carcinoma and then squamous cell carcinoma after that. So it doesn't make up a large proportion of all the skin cancers out there, but it's one of the more deadly ones because it's known to metastasize, and it's known for resistance to certain therapies. And despite all the progress that we've made over the years, it's still one of the top 10 cancers that's diagnosed here in Canada. It's now become, at least in the US, the leading cause of cancer death in young women, ages 25 to 35. And they think a lot of that is probably due to tanning beds and sun tanning. And it's increasing faster in terms of incidence, much more so than any of the other cancers. Oops, wrong way. If you live here in Canada, about half of Canadians will develop cancer in their lifetime, and about a third of Canadians will die from cancer. Of these cases, only 6,800 are melanoma new cases that were diagnosed this past year, with just over 1,000 deaths. Approximately half of these cases are seen here in Ontario, largely because we're one of the biggest provinces in terms of population size, so we tend to see the majority of the melanomas here in the country. Yeah, lifetime probability, if you're male, in terms of developing melanoma is 1 in 57, or 1.7%, and that's increased over the years. And they're predicting that by 2025, that's going to be even much less so than what it is now. And if you're female, it's 1 in 75. Luckily, because most of the melanomas that are diagnosed at a very early stage where they can be surgically removed, and a majority of patients are cured, the 5-year relative survival for melanoma is 90%. This just shows you a graph that says, even though melanoma is not as common as some of the other cancers that you always hear about, like breast cancer and prostate cancer and so on, it is still the fourth most common cancer that we see in young people. especially in people that are ages between 15 and 49. And it is the leading cause of cancer, as I mentioned, in young women. And as I mentioned, it's increasing faster than most other malignancies at about 2.4% per year compared to all the other cancers. Most of the other cancers, the incidence is actually leveling off or going down. The ones that are increasing are liver cancer, melanoma, and thyroid cancer that have been going up. Oops. Okay, I'll get the hang of this. Okay, so just some key facts in terms of how we treat melanoma. Melanoma is a multidisciplinary disease, so when you come to our melanoma clinics, often you end up seeing someone like myself, a surgeon, a dermatologist, plastic surgeon, because we really need all the expertise to help us manage the disease. The main treatment is surgery, as I mentioned, and in general, metastatic disease is incurable, but as you saw today, there's lots of people that are doing quite well with metastatic disease. We know from the past that there have been poor response rates with radiation and chemotherapy, but hopefully this is changing as well with some of the new techniques that we now have, especially in radiotherapy with more targeted types of radiation and gamma knife and so on. That's also changed how well people do with radiation. And as Annette said, until recently, until about 6 years ago, the only drug we really had to treat patients with metastatic melanoma was a chemotherapy called dacarbazine, or DTIC. And thankfully, because of all the breakthroughs that have gone on over the last 10 years in terms of some of the molecules that have been discovered, this has really heralded a new treatment paradigm in terms of how we treat melanoma. So I thought we'd start off with adjuvant therapy and what we mean by adjuvant therapy. So once you've had your surgery and you go in to see the multidisciplinary team at any of the cancer centers and they talk to you about having potential treatment, really what this means is having a treatment in addition to what the surgery that you've already had, where everything has already been removed that we can see. But because there could be microscopic cells that are left behind, there is a risk that the melanoma could come back in the future. And so the treatment is there to try and prevent that from happening and to decrease the risk of the melanoma coming back. And over the last 20 years, there's been lots of treatments that have been studied, all kinds of different injectable type treatments, interferon, chemotherapy, and really none of those treatments showed any benefit except for high-dose interferon. And even the benefit that high-dose interferon shows is quite small, but that is the only drug that's currently approved for the treatment of melanoma. And so when do we think that adjuvant therapy is appropriate, and when do we have this discussion? So there's certain features that we look at that tell us that the risk of the melanoma coming back is going to be higher or potentially quite high. And the kind of things we look at that are important is we look at how deep the melanoma goes into the skin. And the ones that are deeper than 4 millimeters are the ones that we worry about more. The ones that have ulceration, and what that means is not something that you or I could see looking at the mole or looking at the melanoma, but it's something that the pathologist sees when they look at it under the microscope. If there's lymph nodes that are involved, and then the last thing we look at is also something called mitotic rate, which is just a way of looking at how quickly the cells actually divide. And the quicker that they divide, chances are that they're a little more aggressive than they should be. So these are the features that we look at that guide us to decide whether or not we need to do any other treatments once the surgery part has been completed. In general, it's people who have stage 3 melanoma, which means that you've had lymph nodes that are involved, or the higher risk stage 2s, which means that they're deep and they have ulceration. So what's the current status here in Canada? So here in Canada, the only drug that's approved is the interferon for high-risk melanoma. And we know that in terms of benefits, in terms of prolonging how long you have to live from your melanoma, these benefits are relatively low. And because of this, we know that we need better therapies. And you heard from some of the patients on the panel that they were participating in some clinical trials. And certainly that's still, if we have a clinical trial that you could participate in, that's still our first priority, is to get someone on a clinical trial where potentially they could be receiving something novel and hopefully something better than the interferon. The interferon has many side effects for the benefit that you get from it. And there are other drugs that are in clinical trial currently. I get asked often, you know, is there anything else out there that I could have instead of the interferon, or something else that I could do? And the answer to that is, if there is a clinical trial that you could participate in, then look into that. Drugs such as the immunotherapy drugs like ipilimumab, or Yervoy is the other name for it, or pembrolizumab or Keytruda, these drugs are in clinical trials, and they're not currently approved, and they're not available because we don't know what the benefit of these drugs is in this kind of setting. And until we have that information, we won't have those drugs available. We also get asked, you know, do I need to have radiation? When do I need to have radiation? And radiation really is used as an adjunct to having drug therapy if needed. If you have disease where multiple lymph nodes were involved, or the lymph nodes were quite large, or you have cells that kind of escaped the capsule of the lymph node and spread into the tissue, and that's called extranodal extension. So if you have any of those things, then that's the reason that we would use radiation, to try and decrease the risk of something coming back to that area. This paper came out not too long ago, and this was one of the clinical trials that was done looking at ipilimumab, or Yervoy, compared to observation. And this was a European trial that was done, because here in Canada we use interferon, so doing a trial like this would have been quite difficult to offer patients just to be observed. So we didn't participate here in Canada. But basically what this trial showed was that ipilimumab was better than observation in terms of decreasing the risk of the melanoma from coming back and allowing patients to live longer if they had received ipilimumab. This led to the approval of ipilimumab in the US, but not here in Canada, because we also know that interferon was better than being on observation and not having any treatment. So until we have information that says that ipilimumab is better than interferon, then, and there are trials that have looked at that, that's when we'll be able to have that drug here in Canada. The other issue with the ipilimumab is the toxicity that you can get from these drugs. And we'll talk in a little bit more detail about some of the immune adverse events that you can get from these drugs. And some of them can be quite serious. They did have 5 patients die on this trial from the ipilimumab. And some of the subsequent trials with ipilimumab also had patients that died on this trial because of the side effects from these drugs. So it's not something that we're using here in Canada now, but may be available in the future, but at a much lower dose than what was used in this trial, which won't be as toxic as what it was on this clinical trial. And so what I thought we would do before we talk about some of the other drugs, is I would explain to you just a little bit about what kind of clinical trials are out there and what clinical trials are and what to look for if you are interested in participating in some of the clinical trials. There's different types of clinical trials. There's ones that are called phase 1 clinical trials, and these are trials where this is the first trial the first time that these drugs are being tested on humans. So the goal of these types of trials, are to find what dose is effective, look at what some of the side effects are going to be from these drugs, because these are brand new drugs. And often they will test these drugs in a whole bunch of different cancer types and not just one cancer type. These types of trials don't have placebo, because they're testing that one drug to find out what the dose and what the side effects are. Then they move on. Once they get past the phase 1 trials, they move on to what's called a phase 2 trial. And these trials are done in patients with a more specific disease. So for instance, if the first phase 1 trial was done in all types of cancers and they see that patients with breast cancer and with melanoma were the ones that benefited, then the phase 2 trial, they concentrate on those patients. And so the phase 2 trial would then be done in melanoma patients, and they would look at how well the drug works and what some of the side effects are. And these trials don't usually have placebo either. And then they move on to the big trials, which are called the phase 3 trials. And these are the trials that are usually needed before drugs can be approved by Health Canada or the FDA, though there are some drugs that are approved on phase 2 trials alone. And the phase 3 trials are usually big trials where there's lots of patients that are needed for these trials. They're often done across many countries and many different places to be able to do these trials. And often these trials are what they call randomized, which means that you get a 50-50 chance, just like Natalie was saying, in terms of which drug you get. And you don't get to choose, and we don't get to choose. And often these trials are comparing the new drug to whatever the standard drug would be. So the ipilimumab trial that I showed you just before this that was done in Europe, they were able to have that trial compared to just observation and no other treatment, because in Europe they don't have another drug that they use. And sometimes they do use placebo in these types of trials if there's no standard that's approved for treatment. And these are the trials, as I mentioned, that lead to the drugs being approved for us to use. So often for the melanoma trials that we do, that are big phase 3 trials, we're usually involved with multiple countries, often with the US and Europe and Australia and so on, to be able to get the large number of patients that are needed. So over the last, about 10 years ago, there was a lot of research that went into looking at what pathways were involved in survival of melanoma cells. And the pathways that they looked at were pathways that control the survival of melanoma cells. They control how melanoma cells divide and how they proliferate. And they discovered some very important pathways in the process. And one of these is the NRAS BRAF pathway. I don't have a pointer to kind of show you, but that you could see here on the side. And basically, this is a very important pathway in the survival of melanoma cells. And this is one of the driver pathways. And so they discovered all these different parts of the pathway and were able to develop drugs that can block each of those parts of the pathway. And those are some of the drugs that we're going to be talking about in the next little while, specifically the drugs that block the BRAF part of the pathway and the MEK part of the pathway. And we'll talk about what that's led to in terms of some of the treatments that we now have. And as I mentioned, that pathway led to the discovery that melanomas have very specific mutations. And these mutations, when they were discovered, they also discovered drugs that potentially work better for melanomas that have these specific mutations. So overall, about 45% of all melanomas have what's called a BRAF mutation. And if you have a BRAF mutation, it doesn't mean that you're going to be any better off or less better off than anybody else with a different type of mutation. It just means that it gives you options for other treatments, so that it would give you the option for some of the BRAF inhibitors and the MEK inhibitors that have been developed over the years, and we'll talk a little bit about those. What they also discovered is that certain types of melanomas are more prone to have some of these mutations compared to other types of melanomas. So for instance, the ones that are on the skin and haven't had a lot of sun damage, they're more likely to have these BRAF mutations and less likely to have some of the other mutations, such as the NRAS. The ones that occur where there is chronic sun damage, like the ones on the face, for instance, those are less likely to have BRAF mutations. The ones that we call mucosal melanoma, which are melanomas that can happen inside the mouth, in the sinus cavity, in the vaginal areas, anal areas. These are quite rare melanomas, but these melanomas rarely have any type of BRAF mutations. And then there's the ones that can occur on the soles of the feet or your hands, the nail beds, and those are called acromelanomas, and those also often do not have BRAF type mutations. And then uveal melanoma, which we heard a little bit about, these have very specific mutations that now there are some drug development that's going on looking at those specific mutations. And we'll talk a little bit more about what some of these mutations mean. So In terms of, as I mentioned, with the adjuvant therapy, I wanted to just bring that part of it in a little bit, just to tell you about what some of the trials are that are happening. Currently, the one trial that we do have going on is a trial that's comparing pembrolizumab, or one of the new immunotherapy drugs, to interferon. And this is one of those phase 3 trials where it's a random comparison. You need to have lymph nodes that are involved to be able to participate in the trial, because they're taking high-risk patients. And the reason that it's being compared is because we know that pembrolizumab works very well in patients that have stage 4 melanoma, and you heard from a few of our panel today who are on these drugs and are doing quite well. There are 6 other trials, 5 others that have now closed and are done and completed, and we're waiting for results. There's a couple of trials for BRAF mutated patients where they've looked at these BRAF drugs and to see whether there's improvement using these drugs for those specific patients. There's also a trial that looked at interferon compared to ipilimumab, and that's the trial that we're waiting for here in Canada to see whether it's going to be better than interferon. And then there's also trials that have compared new immunotherapies such as the pembrolizumab to interferon, and there's also a trial that looked at nivolumab with ipilimumab. And so hopefully with all these trials that have gone on over the last many years, in the next year or two we'll start to get some of these results, and we'll hopefully have something better than what we have now with interferon. Okay, so with that we're going to move on to metastatic melanoma, which is the stage 4 melanoma, and talk about what some of the therapies and some of the trials that are out there now. So prior to, and Annette had touched on this as well, prior to 2010, we really didn't have a lot in terms of treating melanoma, and there was a lot of different trials that were done looking at all kinds of chemotherapies, and none of them really showed any improvement in overall survival for any of our patients. And so we call this the area of futility, because there was a lot of trials, and many of us who would go to the meetings and we'd listen, you know, all these things, and everything was always negative. It was quite discouraging and depressing going to these meetings until things changed about 6 years ago. And now we call that the area of hope, because now we have all these drugs that are working and keeping patients alive much longer, and we see these dramatic results with these drugs, and we're hoping that things keep getting better as time goes on. And so since 2011, we have 7 drugs that have now shown an improvement in overall survival and have been approved by Health Canada, and 4 of these are the BRAF MEK drugs for BRAF mutated patients. We talked a little bit about the ipilimumab, the pembrolizumab, and the nivolumab, which are the new immunotherapy drugs, and we'll talk about these. So this is just to give you a little bit of an overview in terms of how we, as physicians, how we look at what the options are for patients with metastatic melanoma, and how we sort of think in our head how we're going to sequence these drugs and what's the best sequence to use to get the best benefit out of all these different drugs that we have. And so, as I mentioned earlier, if you have a BRAF mutation versus not having a BRAF mutation, which is the BRAF wild type melanomas, it doesn't disadvantage you in any way in terms of how you're going to do in terms of your melanoma. It just gives you different options for therapy, so that if you have the BRAF mutation, you have options for the BRAF inhibitors, where people who have the BRAF wild type would not have that option. Okay. So in terms of strategies for targeted therapy, there's really 2 different strategies that have come along in the last 5 or 6 years. And these strategies are either targeting the host, which is what we do with immunotherapy, where the immunotherapy does not directly kill the cancer cells or the melanoma cells. What it does is it drives your immune system to do that for you, and that's why we're targeting the host. The other way to do it is to target the tumor inhibitors, and the MEK inhibitors do. They're targeting those survival pathways within the melanoma cells to try and stop those melanoma cells from growing and dividing and causing problems. Okay, so we're going to talk a little bit first about the targeted therapy where the drugs target the tumors, and I've listed there what the BRAF inhibitors are that we would use in someone who has a BRAF mutated melanoma, and that's the dabrafenib and trametinib, and the vemurafenib and cobimetinib. And we train hard to try and pronounce these names on a daily basis. And they keep coming up with new ones, which we have to practice. So in terms of the BRAF drugs, there's two inhibitors. The good thing about these drugs is that they're pills, they're oral drugs, so you don't need injections, you don't need to come to the chemo unit for treatment. You take these at home on your own. There's several that we use now, but there's also other ones that are being developed. The good thing about these drugs when they were first developed is that they act fast and they work in a lot of people. But initially, when we were using just the single drugs, what happened often is that they didn't work for a long period of time because the tumors got smart and they got resistant to these drugs. So over time, we've actually made this better in that we now use a combination of the dabrafenib and trametinib, which are BRAF and MEK inhibitors. So if you remember from that pathway that I showed you earlier, and you saw sort of the different parts of the pathway, what this combination does is it targets 2 spots on the pathway instead of 1. And what that did was it gave us much better response rates so that we know that they work better when we use them in combination. The response lasts much longer than it did with single agent drugs, and it improved how long people lived from their melanoma by using the combination drugs. We now have 5-year results for these drugs because they've now been out long enough that we're able to get this data from the clinical trials. And we know that at 5 years overall, about 30% of patients are still alive who have taken these drugs. And if you have good disease, if there is any such thing as good metastatic disease, and these are usually people that don't have a lot of disease, that often have only a few areas of disease, these patients tend to do even better, and there's about 50% of people that are still alive at 5 years, which 10 years ago was unheard of with anybody with melanoma. So there are also other combinations that are being looked at and are being studied, and hopefully we'll have even more in the future. These drugs are generally well tolerated. Not everybody tolerates them really well. Some people have more problems than others, but on the whole, most people tolerate them pretty well. The most common side effects with these drugs are fevers and chills, skin rash, sometimes aches and pains, sometimes diarrhea. And if you're on the vemurafenib combination drugs, then there's a lot of issues with sun sensitivity and photosensitivity. We tend not to use the vemurafenib combination as often. We usually start off with the dabrafenib and trametinib complication because of the photosensitivity issue that you can get, especially, we live in a place that's quite sunny quite often, and to have to be worried about being exposed to the outside and getting burned, we try not to use the drugs unless you don't tolerate these ones. There are also less common side effects where it can affect the heart and the eyes, but that's very uncommon in less than 1% of patients. And I'll just show you some examples about some of the side effects that can happen with these drugs. You can get most of the time the skin rashes are actually quite mild, but you can get a severe rash on these drugs, and so we manage those if that happens, but that's also very uncommon. If you could see the feet, that just shows some calluses on the bottom of the feet, which can be quite bothersome and quite sore for people. We used to see that a lot more when we used the single agent drugs. Now that we use the combination, we tend not to see that as much, which is good. It's much less of a problem. And as I mentioned, the eye issues, you can get an inflammation in your eye from these drugs, but that's extremely rare. It's in less than 1% of patients that can happen, but we usually talk to our patients about what kind of things to look for and when to be worried about something and to call us if something was happening. So I also mentioned on the pathway that I showed you, there's something called an NRAS mutation, which is sort of higher up in the pathway. And This mutation is not as common. It's in about 20% of patients with melanoma. There have been some clinical trials looking at specific drugs for this type of mutation. They haven't been as promising as the BRAF mutation drugs, but they did show an improvement over chemotherapy. And so for someone who does have an NRAS mutation, potentially one of these drugs could be used if they didn't do well on the immunotherapy or some of the other drugs. None of these drugs have been approved yet for the NRAS mutations because the results weren't as great as we were all hoping they were going to be. So we're waiting for more clinical trials and newer drugs to be developed for the NRAS positive patients. And then the last thing, one of the other pathways is called a c-KIT mutation. And c-KIT is one of the pathways that's involved in the development of your melanocytes. And the melanocytes are the cells in the skin that give you pigment, and that's where melanoma comes from. And these are the mutations that are much more common in the very specific types of melanoma, such as the acromelanomas that I showed you pictures of with the hands and the feet, or the mucosal ones, which are the ones that happen in the mouth and the nose and so on. And these types of melanomas are quite rare. And the chances of having one of these mutations with those types of melanoma is about 10%. There are specific drugs that are developed for c-KIT mutations, and there has been some clinical trials looking at some new drugs that have recently closed, and we're waiting for some of those results. But we do have imatinib or Gleevec for patients that have c-KIT mutations. And this is when we use our reimbursement specialists like Allison or Dina, because there is a program that we can get the drugs paid for someone that has a c-KIT mutation. Okay. So we'll move on to the other strategy for targeted therapy, which is the immunotherapy. And this is the strategy where the drugs actually target the host to enhance your immune system. And on the side, I wrote what the drugs are that we have available now, the ipilimumab or the Yervoy. I wrote the trade names. I tend not to use those, but I know if you go on the internet, most of the time you'll see the trade names instead of the drug names that we're used to. So the ipilimumab or the Yervoy, the pembrolizumab or the Keytruda, or the nivolumab or Opdivo. The pembrolizumab and the nivolumab are basically sister drugs. All the studies have shown that they have the exact same efficacy, the exact same side effects. They're basically the same drugs, except that they're made by two different companies. And we tend to use the pembrolizumab more because we give it every 3 weeks, whereas the nivolumab has to be given every 2 weeks, and it's just more cumbersome to have to make more visits. But they work exactly the same. So in terms of how these immunotherapies work, and as I mentioned, they work by targeting the immune system and specifically the T cells. So the T cells are the cells in your immune system that function to hunt down and destroy cells that are infected or fight off germs or things that have become cancerous, something that looks foreign to your body. That's the job of the T cells. And the T cells have molecules such as the CTLA-4 molecule that basically shuts it off when it's done its job and it's done what it's supposed to do. And if it didn't do that, we'd all run into problems with potentially developing autoimmune diseases because your immune system is just going and going and going and potentially could attack other parts of your body. So it has a mechanism to shut itself down. And what drugs like ipilimumab do is it blocks that CTLA-4 so that it prevents it from shutting down the T cells, so that the T cells can keep going and going and going and go after the cancer cells. Okay? And drugs like the nivolumab and pembrolizumab do the same thing, but they block another molecule that's part of the T cells that also helps shut it down once its job is done. So that the function of these drugs are to block areas of your immune system that shut it down, and they just allow your immune system to keep going and going and going. So the one good thing about the immunotherapy is that it works and works well regardless of what your BRAF mutation status is, regardless of what your NRAS mutation status is. So the mutations don't matter in terms of the immunotherapy part. Currently, we have, as I mentioned, the ipilimumab, the pembrolizumab, and the nivolumab that are all approved and funded here in Ontario and across Canada. But these immunotherapy drugs have some very unique properties compared to chemotherapy that we're used to. So they're very, very different from chemotherapy. They act differently because chemotherapies are more the types of therapies that go after the actual cancer cells. And this is going after your host. And the side effects are very, very different in terms of the immunotherapy, and we'll talk about that. So some of the unique properties, one of the things is what we call pseudoprogression, and I'll explain in the next slide sort of what that is and how we sort of look out for that. The other unique property of these drugs is that they last for a very, very long time, and patients can do well on these drugs for a very long time, for years on these drugs. And that was unheard of years ago in someone who had melanoma. And they have these unique side effects as well, which we call immune-related adverse events, which we'll talk about and talk about what kinds of things to look out for. So this is a picture of someone who had a melanoma next to their kidney, a melanoma mass next to their kidney, and you could see there at the baseline, and also a nodule in the lung, which is inside that little circle. And this is a patient that had what we call pseudoprogression when they were treated with pembrolizumab. So what that means is that what can happen when you're on these immunotherapy drugs is that, as I mentioned to you, the T cells will go after and try and fight off the tumor and attack the tumor cells. And by doing that, what they can do is they can actually infiltrate the tumor and make the tumor look bigger. And so often things will swell up before they actually start shrinking down. And often, you know, it's bothersome to everybody to see things growing, obviously, even for us. It's stressful watching things grow, but we know that sometimes it'll shrink down if we give it enough time. And so that's what we call pseudoprogression. And you could see here at week 12, the masses are much bigger than they were at baseline, but then 4 weeks later, things have shrunk down again. And so that's what we usually do. If we're suspicious that something is not a real cancer that's growing, then we repeat the CT scans about 4 to 6 weeks later, look at it again, and if things are shrinking, then that means that the drug is actually working and doing what it's supposed to do. Okay, so that's one of the unique things, because we never saw that with chemotherapy. And as I mentioned, the other unique thing is how long the benefits of these drugs really last. And one of the first drugs in immunotherapy that we had approved was ipilimumab. And what was impressive about ipilimumab is how long the responses lasted with this drug, because it doesn't actually work in a lot of patients, unfortunately. It only works in about 12 to 15% of patients, but if it works, it tends to work really well. And now we have data that's out 10 years, and we know that if at 3 years you've done well on this drug, chances are that at 10 years you're still going to be doing well on this drug. So we have data that says at 3 years is about 22% of patients that are still alive and doing well. And that sort of tail that you see there that keeps going is what's called a tail of the curve, and it just basically shows that that result just keeps going. So that if you did well at 3 years, you're going to be well at 10 years down the road. And that's something that was unheard of with conventional chemotherapy. Okay, and I'm just going to show you about some of the other drugs. So this is the pembrolizumab, and one of the first studies that was done with pembrolizumab. And the graph, basically the way these waterfall graphs work is that anything that's on the bottom underneath is good. Okay, that means that the cancer was shrinking. Anything that's above means the cancer was growing. And so basically in the first trials that they did looking at these drugs, they saw that there was about 70% of patients that did really well on these drugs and had some improvement in their cancer. And what they also saw was that 2 years later, there was about 70% of patients that were still on this drug and still doing well. And this was also unheard of with any drugs, let alone immunotherapy, because this was much better even than what we were seeing with ipilimumab. And now we have much longer results from these trials and from these drugs. And one of the other drugs that it was tested against was against ipilimumab. And this is the reason why we now use pembrolizumab instead of ipilimumab up front, because we have this trial that showed us that it was much better to use pembrolizumab up front because the survivals were better and patients did better, and more patients did better on pembrolizumab than they did with ipilimumab. And we now have 3-year information for this trial, and there's still 50% of patients that are doing well at 3 years compared to 39% of patients who had ipilimumab. And this just shows you that the nivolumab is also very similar, almost identical to what we see with the pembrolizumab. We have a little bit longer data with this drug compared to the other ones, though, because it came out first. Sorry. So one of the other things that's come along is we know that, because we know that the pembrolizumab and nivolumab by themselves, patients did really well. We know that with ipilimumab, patients can do really well and be alive for a long, long time. And then the concept came up of what if we combine these two drugs together? Is the combination of these two drugs better than just being on a single agent by itself? And what they showed was, yes, it is, but there are some consequences to combining these two drugs together. So what they found in the clinical trial was that the chances of doing well on this drug was higher, and more patients did well on this drug. So you could see that there was about 57% compared to 43% and 19% of patients who actually benefited from this drug. But the chances of having a side effect or treatment-related side effect was much higher with the combination drug than it is with single agent. So if you could see on the bottom, it's 55% of patients had issues with pretty severe side effects from the combination compared to 16% on single agent nivolumab and about 27% on the ipilimumab. And so that brings us to the next topic in terms of what are these immune-related adverse events that we all worry about. So it became clear that early on, when we first started using ipilimumab, that ipilimumab induced some kind of immune-related inflammatory type side effects. And they, through biopsies and sort of blood tests and so on in patients who were having some of these side effects early on, what they saw was that the mechanisms that caused these side effects seemed to be related to the T cells. Because when they did the biopsies, they found that there were T cell infiltrates, and that it was mostly T cells that were causing issues in terms of inflammation of the skin or inflammation in the gut or other areas. And the most common things that they saw were colitis, so affecting your bowels and causing severe diarrhea, skin toxicity where you got pretty severe rashes, effects on your thyroid gland, adrenal gland, pituitary gland, those types of things. And, and so what they saw initially with the ipilimumab study was that there was about 60% of patients that got some kind of immune-related event, but only about 10 to 15% of these were actually serious immune-related events where we had to treat with steroid drugs to get those under control. We do know that with ipilimumab, there's a relationship between the amount of side effects that you get and the dose. So the higher the dose of ipilimumab, the more chances that you're going to get some kind of severe side effect from that drug. And when can these happen? They can pretty well happen anytime when you're on any of these treatments, whether it's ipilimumab, pembrolizumab, the combination, whichever. But often they tend to happen after the 3rd or 4th dose. And we kind of get a little bit of false sense of security because everyone feels so well after the first one and nothing's happening. And then as time goes on, sometimes things start to happen. It tends to be that the rash tends to happen first. The diarrhea tends to happen earlier on. And other things like affecting the liver or affecting the pituitary gland or the thyroid gland, things like that take a longer time to develop. However, though, most of these all of these can be treated and things can go back to normal. And most of the time we try and keep you on the drug if we can. The other part of this is that the immune-related side effects that you can get with these drugs, with any of the immunotherapies, can pretty well affect any part of the body. So anywhere that there can be inflammation, it can do that. So it can affect any of the glands that we talked about. It can affect the lungs and cause pneumonitis. It can affect your kidneys. It can affect your liver, your skin, your eyes, pretty well anywhere. The trick is to catch these early enough so that we could treat them quickly and get them under control so that you can continue on with your treatments and not have delayed side effects from these drugs. The other reason that we like pembrolizumab over ipilimumab is that the immune-related side effects are much lower on pembrolizumab than they are with the ipilimumab drugs. This table here just kind of shows you a comparison of what some of the different side effects are and with the different types of agents that we use. So the combination of nivolumab and ipilimumab has the highest types of side effects related to the drug. And often when you're on the combination, you can also get multiple different types of immune-related side effects all at once. The single agent nivolumab has the lowest, as well as the pembrolizumab, and then the ipilimumab is kind of in between. And the more common things are the diarrhea and the colitis, as I mentioned before, and some of the skin toxicities and the effects that can happen on the liver. So, as I mentioned, some of the basic principles, many of these can happen within the first 12 weeks of therapy. We watch out for these. You get tired of us asking you every time you come into clinic if you're having any of these side effects. But we do that because we want to try and catch these early so that we can manage them early and get them under control. The main treatment is steroid therapy, so we use big doses of steroids. And often the steroids you're on for about 4 to 6 weeks when you're on these drugs to get things under control. But these things can also happen later, and it can even happen once you've stopped the drug and can happen a year later once you've stopped the drug. Because, as I mentioned earlier, the way these drugs work is that even though the drug is not in your system, your immune system has been activated, and that's what's causing the side effects to happen. If you were to develop any of the issues with the thyroid or the pituitary gland or anything like that, often those types of treatments require hormone replacements, so we would treat you for those if that was to happen. The other thing that's important is people often worry, if I'm going to be on steroids, is that going to affect how well I do on these drugs? And there's lots of data that tells us that that's not the case. So even though we've put you on steroids and suppressed your immune system for a short period of time, doesn't seem to affect how well you're going to do on the drugs. And this just shows you some examples of some of the symptoms to watch out for and some of the questions that we ask every time you come to clinic in terms of how you're feeling and are you having any diarrhea, do you have a rash, and so on, for us to try and make sure that there isn't anything going on. So just to summarize, we've had lots of different developments over the years. We know that these targeted therapies that we have now are pretty amazing. We see some great responses, some quick responses, and many of these are long-term that we're seeing, especially with the immunotherapy. We have the 3-year data now where 50% of patients are still doing well. We now also have the combination of the 2 immunotherapy drugs, which show even more impressive results, but this comes at a cost with the toxicity and the side effects that you can get from having the combination. In the future, there's lots of new other immune type modulating drugs that are being developed, and they're also developing new combinations that aren't going to be as toxic as what we're seeing with the nivolumab and ipilimumab. And the hope is that some of these therapies are going to translate into the adjuvant therapy setting where we'll hopefully have less metastatic disease and more patients that are cured up front so that we don't have to use these drugs in the future. And so just to end, I borrowed this from one of my colleagues because I thought this was really good. This is what it was like in the past. We hardly had anything. It was pretty barren for melanoma treaters. And this is sort of where we are now, where we have some really good drugs and we've made a lot of progress, but you know, as you can see from the numbers, there's still a substantial number of patients that aren't getting benefit from these drugs. So we really need to do better, and we need to have better drugs where most people are actually benefiting instead of a percentage of patients that are benefiting. So with that, I thank you very much, and I'm happy to take any questions.